Good morning. We will have a ward discussion. Today we will have a ward round discussion followed by an operative step discussion on repair of peptic perforation. Dr. Nitesh Pradhan is second year junior resident at MR Bangur Hospital. He will present. And Professor Gautam Das, who is professor of surgery at IPGM RSK Hospital, will take us through the scenario. So first, Nitesh, you share your screen to show the ward round scenario. So now I find there are 4 ward round scenarios for the individual.
Good morning, sir. 26 male presented to emergency with complaints of generalized pain abdomen. On examination, patient has a toxic loop and is tachycardic and hypotensive with rigid tender abdomen and absent bowel sound. How will you proceed with this patient?
Let Dr. Das ask you how you want to start. This is a scenario the patient has presented to you.
Presented in the emergency, generalized pain abdomen, patient has toxic loop, and so proceed for the clinical findings. Other clinical findings you have to see, and how to proceed.
Yes, sir. Yes, sir. Sir, other clinical finding on examination, sir, are
No, Nitesh, I try to understand. You have given a scenario where the patient is tachycardic and hypotensive.
Yes,
so these are the patients who are in emergency. You are looking at the patient the first time. Once you find the patient is hypotensive, it is not the time to proceed with detailed history, examination, investigation. Here the approach should be, sir, the patient is tachycardic hypotensive. I will follow ABC.
Yes,
once the patient is stabilized to some extent, I will proceed with details. So here the steps should be, I will first start resuscitation of this patient and then go into the details of the history, examinations, whatever is required, do relief investigation. Dr. Das, I think that should be the right approach.
Yes, that is quite like ATLS. You have to simultaneously go for resuscitation and examination.
Yes,
primary survey and secondary survey, though it is not mentioned like ATLS, but you have to do that in emergency.
Sir, I'll start with resuscitation of the patient. At the same time, send the blood for the routine investigation.
Tell us what are you going to do now? You say resuscitation. Sir, what is resuscitation in this patient?
Sir, I'll start with IV fluids. Initially with fluid bolus of around 1 liter, NS or RL. And then, sir, I'll do Riles tube for prevent prevent aspiration and vomiting, and further contamination and for abdominal for decompression of the guts. Sir, I'll do urinary catheterization to monitor the urine output. Sir, I'll start with antibiotics, analgesic.
What fluid you will prefer?
Sir, normal saline, ringer lactate.
Okay.
Say one. You see, when you have a patient who has got a situation of pain abdomen, suspected peritonitis, so they are the patient where you should understand what might be the underlying acid-based situation related disturbances. If this patient is vomiting to great extent,
Yes,
he is likely to be in a metabolic alkalosis. If he is vomiting less and he has a lot of sequestration of gut contents, then it's likely the patient is metabolic acidosis. So if he is likely in a metabolic acidosis state, you start a ringer lactate solution. There is no harm.
Yes, sir.
If he is having a situation that he is a intractable vomiting, then he might be in some metabolic alkalosis state. In that case, you can study normal saline. So choice is between either normal saline or ringer lactate solution based on the patient presentation. And likely you have not done the ABG straightway. So you have to start a fluid based on your just clinical assessment.
Yes, better you can start with normal saline without any.
Yeah. Okay, so these are the basic things you follow. Once the patient comes with a situation of tachycardia hypotension, otherwise patient is normotensive, pulse is around 80-90, you start with the usual steps of history, examination, investigation, and then treatment. So on arrival, you resuscitate the patient with IV fluid, give the patient some analgesic, he is in pain, then nasogastric aspiration, antibiotic. These are the few things that should be done on arrival. And then you proceed. You see, you have given very little about the history, just complete generalized pain. So in this case, you should now go to the little more about history. So tell us what is important to know from the history in this patient. You got only one clue, generalized pain abdomen.
Sir, I'll ask for the when pain abdomen started and how it progresses. Like in peptic perforation, initially the pain started at right upper quadrant. Then the pain will be at the right iliac fossa and then get generalized. So, then the patient may be associated with vomiting and fever. And
rigid tender abdomen, absent bound sounds indicates some likely diagnosis of underlying peritonitis.
Yes.
So here,
I'll ask
here detailed history about the pain, which goes by Socrates, site, onset, character, okay, relieving factor, aggravating factor, okay, then timing of the pain. So the other things, apart from pain now, I thought it's a perforative peritonitis. So it can be appendicular perforation, it can be a small gut perforation, it can be large gut perforation, it can be peptic perforation, commonly is peptic perforation. So in that case, history should point out whether he has got any other associated symptoms, like the pain starting in the right iliac fossa, and then become generalized. Likely that's appendicitis. Patient starting in the left iliac fossa. Patient has history of chronic constipation. Patient has some other features of bowel disturbance. It may be a severe diverticulitis with free perforation. So you have to think of the different underlying causes. This can be enteric perforation. In that case, patient may have fever which is lasting for about 2 to 3 weeks, and then he presents with acute pain abdomen. So keep in mind the important possibilities, and then try to
proceed for a proper diagnosis. Yes, and what are the possibilities you should think so that you can proceed to further history taking. Professor Saha had mentioned the perforative peritonitis, and it may be appendicular perforation also. But another thing you have to keep in mind about the pancreatitis. This may present similar features, not same. So what thing you have to ask?
Sir, I'll ask in case of pancreatitis, the pain will be, sir.
You don't know the case, but you have to keep in mind what are the things I have to have had Professor mentioned that when did pain start, whether the pain was continuing with mild pain like appendicitis, it was continuing, then because appendicitis usually should not get suddenly perforated or with sudden onset of pain. But in case of perforation, it may appear suddenly. There may be a food intake and just after taking some food. But
or maybe a following bout of alcohol. Okay.
Yes.
Or the other patient who may be secondary to gallstone disease. So patient had a biliary colic earlier, and now suddenly it's a epigastric pain getting generalized. It's likely that it may be a gallstone pancreatitis.
So alcohol is an important history. So you have to take always the history of alcoholism. Okay, proceed.
Sir, I'll also ask for the history of chronic use of NSAIDs or steroid.
And also prolonged use of PPI and H2 blocker like that for upper abdominal periodic pain.
Sir, I'll ask for the history of peptic ulcer disease.
Yes.
Any history of tuberculosis is important?
Yes, sir. I'll ask for the history of weight loss And
whether he was with some prolonged illness, that may be a long-standing like tuberculosis, or maybe shorter history of fever like enteric fever.
And then previous history of chronic pain, abdomen, diarrhea, which might suggest underlying inflammatory bowel disease like Crohn's disease. So in the history, you should ask about, you first think of what might be the underlying cause. It's unlikely to be just intestinal obstruction. It's a rigid, tender abdomen with absent bowel sound, so it's more towards a peritonitis. So peritonitis is secondary to some underlying pathology. What you see, you always think of the conditions you see in your 3 years practice. If you see 3 years practice, if you put the common causes may be number 1, peptic perforation.
Yes.
Next should be appendicular perforation. Next should be small gut perforation. It can be rarely a cholecystitis with gallbladder perforation, although rare. But you should always keep in mind that what you see in your context. Don't bring out some rare causes in ward round discussion. Ward round discussion is done in the ward, and you should be always confined to your orientation in 3 years. Okay, you think a patient has got a tubercular pathology, so it can be tubercular perforation. So confine your attention to these few things, and most of the time you'll be right.
Yes. So what will you do?
Sir,
and the history, another important is in the past history, you should find out whether he's got any comorbidities. Even 26 years old patient may have hypertension, he may have diabetes, he may be on some drugs for some reason. So in the past history, you should find out this important history. Any comorbidities, that is important because that is bearing on management also.
Sir, on examination, on general examination, patient look is toxic.
That is already said. What do you like else to see on general examination? 3 points are already told. Patient is looking toxic. He has got tachycardia. He has got hypotension. What else you like to look?
Sir, I'll look for the dehydration.
Yes, hydration status.
Yes, sir.
Okay, patient is looking toxic. He is unwell. Okay, look for any evidence of dehydration. How do you assess dehydration in a patient in emergency?
Sir, in dehydration, patient will be having dry tongue, sunken eyeball.
First is patient will be thirsty.
Thirsty.
Patient will be thirsty. And then if you examine the patient, you find dry tongue. What else?
Sunken eyeball.
Sunken eyeball.
Sir,
dry conjunctiva.
Dry conjunctiva.
Okay.
Skin turgosity.
Tongue will be dry. Tongue will be dry. And
sir,
skin turgor will be lost. And
sir, urine.
Obviously, patient will have tachycardia, may have hypertension also. And objective assessment is by urine out. So this is the way you assess dehydration.
Yes, sir.
Okay. What else? What else you look for in general examination? You see, vital assessment is very important. Vital assessment is already told about these 2 points. So if you go by quick assessment of vitals, these are all recorded. And then you should assess the nutrition status also.
Yes.
Because nutrition is important to plan surgery. If you want to do a gut resuscitation anastomosis, you should think whether he is preserved or not, because that is one important factor will decide about the outcome of the anastomosis or closure of the perforation. Okay.
And you also see the response of your fluid challenge.
Yeah.
Yes, sir.
Why urine color, change of urine color.
Yes,
and
sir.
also it is important that in case of you can differentiate somewhat. In case of pancreatitis, your response will be slower because pancreatitis with hypotension will respond less quickly than with
More
peptic.
fluid secretion.
Okay, then you have told that there is a rigid abdomen, but again you have to palpate where the rigidity and tenderness is most.
Yes, sir.
Especially in appendicular perforation, you will see that this lower abdomen on the right side is more rigid and tenderness will be more there. And in case of, obviously, in case of duodenal perforation, you will get the upper abdomen. There is more rigidity. Okay. Then what will you do?
So I'll go for the per abdomen examination, where I'll find a respiratory movement will be lost, and respiratory movement of abdomen will be lost, and rigidity and guarding. Then
what is the difference in attitude of the patient? Suppose the patient has got a colic
patient will
and
be
patient
lie,
has got underlying peritonitis.
sir, in peritonitis, patient will be lie still.
Yes. So patient is loath to move. Patient remains standstill, but in colic you will find he is restless.
Yes.
So if you find the patient is lying quiet in the bed, that is one solution, that he doesn't want to move because movement causes pain.
Yeah.
Now, what is percussion tenderness?
So it is a rebound tenderness.
This indicates extreme tenderness. So in that case, if you just percuss at one point, you will find tenderness. That indicates peritoneal irritation.
Yes.
It may not be always a standard at that, but even a underlying peritoneal collection, peritonitis can also cause some percussion tenderness.
Yes.
And then already you say that bowel sound is absent.
Yes. So there will be obliteration of liver dullness.
There will be. How can you know? You said I will percuss and find out whether the liver dullness, because if you clinically find liver dullness obliterated, your diagnosis is more clinching towards a perforative peritonitis. Yes. So in percussion, you say I will also percuss to find the liver dullness. If the liver is obliterated, I feel that there might be some hollow viscous perforation. Yes. Okay. Any role for doing a rectal examination?
Yes, sir. Rectal examination, sir, will find the tenderness while doing a rectal examination. Tenderness in the rectovesical region, and
that depends. If you have a pelvic collection, you can find it. If the primary diagnosis is appendicular perforation, you may have tenderness in the right lateral rectal wall. So that depends on the underlying pathology.
Yes. Especially that is an important clue, though not mentioned in the many books, but we have seen practically in case of appendicular perforation, you will get more tenderness on the right side of the rectum.
Yes.
Now proceed. What will you do?
You see, what I'm telling to everybody, this part is important. In what on exam I find, a lot of boys does not know the approach.
Yes.
If you are given a scenario, you always try to think that how to face the scenario. You don't just jump to the examination. If you are given a scenario in the examination, you should try to take some points in the history and then do a relevant examination and then plan for investigation. Because your approach is important.
Yes.
If your approach is right, you can answer well. Suddenly you study the examination. Not anybody will accept that you study the examination of the patient, because you are given a scenario like this, maybe 2 or 3 lines, and then you have to keep on elaborating on this scenario. Okay, so examination is done. You have a suspicion of perforative peritonitis in view of the tenderness, rigidity, absent bowel sounds, and the history of pain, and possibly you have a more inclination towards a peptic perforation being the cause. But nobody can be certain. You see, if you have a classic history of peptic ulcer disease, pain starting in the right hypochondrium and then descending down the iliac fossa and then become generalized, it points more towards peptic perforation. But nobody can be sure of a diagnosis pre-op. So keeping in mind a perforative peritonitis, what would you do next? Because already your resuscitation is on.
Yes.
You start IV fluid, you analgesics, antibiotics, nasogastric aspiration, Police catheter. These are very basic things you should start doing in an acute abdomen patient. Sir,
I'll proceed with investigation. Sir, I'll do chest X-ray with both domes of diaphragm.
Now, first issue for scenario like this, you start with lab investigations. Chest X-ray, you need to send the patient to X-ray department, but while drawing the IV line, you say some blood investigation is important in this patient. Yes, some basic blood investigation is important in this patient, like.
Sir, like CBC.
What? How is CBC helpful?
Sir, WBC count will be
increased.
Yes. Neutropenia.
So if it's peritonitis, you have to do a complete hemogram in the form of hemoglobin, which may be lowered to a complete blood count, where there may be increased total count with polymorphonuclear leukocytosis.
But you should take the blood after some resuscitation, because in the initial stage you may get very high hemoglobin, because there is a dehydration. You will get hemoglobin more than the normal. Okay, proceed.
Sir, I'll do serum electrolyte, urea creatinine. Then sir,
this urea creatinine is deranged somewhat, and it may not influence your treatment very much in doing it initial stage. But important thing you have to test, you may do a amylase.
Yes, sir.
Along with that.
Liver function test,
yes.
serum amylase. Like
so there are some baseline investigations. You
yes.
see, the point is told that you will not enumerate the whole list.
Yes.
You should think of this underlying patient in front of you and
yes.
you plan.
Yes.
So if you have a perforative peritonitis, one DD should be pancreatitis.
Yes.
So in that case, you have to do a serum amylase lipase.
Yes.
Lipase is more important. And then electrolytes, blood sugar.
Yes, blood sugar.
So these are the basic baseline investigation required for any patient present emergency.
That may influence your further line of treatment. Those are important.
Then you say chest X-ray.
Yes, sir.
What chest X-ray? Supine?
No, sir. Erect chest. Erect position.
Erect position chest X-ray. So I give this, this patient on chest X-ray, there are some chink of air in the right rim of diaphragm. The report has come. What next?
Free fluid, free air will be seen in the both the dome of diaphragm. Then no further investigation.
Okay, that is important. You see, ultrasound now is a very basic investigation. Okay, so ultrasound is in the ward. Surgical medicine is supposed to be ultrasound. Ultrasound extension clinical examination. To say ultrasound, there is no harm. It is an extension of clinical examination that can show you the underlying fluid in the abdomen. Okay, but patient having such tenderness, rigidity, it is sometimes difficult to run the ultrasound probe. Patient will have severe pain.
Yes.
Okay, so you have free gas and diaphragm. Your answer should be, sir, that indicates patient has got a perforative peritonitis. He will need laparotomy. Yes. So I will prepare the patient for laparotomy. So it's no point asking to have a CT scan in this patient. Okay. Yes. So if you don't find free gas and diaphragm, then 30% patient of peptic perforation, patient with appendicular perforation will not have free gas. Yes. So you may have pancreatitis without free gas. Yes.
Acute pancreatitis. If you do not get gas, there are few possibilities. There may be certain percentage of peptic perforation and maybe appendicular perforation, or maybe.
Why in appendicular perforation don't find free gas?
Sir, because the very little amount of free gas is
usually obstructive type of appendicitis perforates. So if there is an obstruction in the appendicular base, hardly 2 to 3 or 4 cc, 5 cc air is leaked out. So if there is a perforation involving the base of the appendix, then only you can have free gas. Otherwise, in appendicular perforation, free gas is not easily found. So suppose free gas is found. So what is the optimal time that you take the patient for surgery? Because these are the patient admitted emergency. And I find sometimes boys take this patient to the theater within half an hour, 1 hour.
Sir,
is that so emergent?
Sir, no. We'll note the few points. Sir, we'll stabilize the patient by seeing urine output,
yes,
blood pressure, yes, and heart rate.
So this is important. You cannot take a patient who is hypotensive, who is having a renal perfusion is not yet established. You cannot take the patient for surgery, because these are the patients who are having peritonitis with gram-negative sepsis. So these are the patients who have the issue spend some time for resuscitation.
Yes.
And once the patient, you feel, is stabilized to some extent, he may not come to absolutely normal range. Yes. But at least patient should have adequate hydration, yes, assessed by objective urine output, and then some change in some improvement in hypertension, and the pulse rate might go down to some extent. It may not come to normal.
Normal, yes. One most important indication for in such scenario is urine volume. Urine color will change.
Yes.
You can tell that your hydration is going adequate line, and also electrolyte is also important if you can do that. Then, so as Professor Shah said, resuscitation, at least to a great extent, resuscitation is very important for proper outcome. If you go for surgery without proper resuscitation, your result will not be that good. Your anesthesia risk will be great, and also your result on the or ischemic or hypotensive gut, your sutures may be not that good. Then what will you do?
I'll plan for exploratory laparotomy and primary repair of perforation.
First is exploratory and diagnosis. That is important. You have not diagnosed what is wrong. So what should be your incision in this patient? If diagnosis is not made beforehand, what should be your standard incision?
Sir, upper midline incision.
Upper midline. Fine appendicular.
Sir.
Why do you take the incision to the fire? What is that called as? This is known as a midline incision.
Yes.
Okay. For laparotomy.
Especially if you do not get figures under diaphragm, you must give your incision, put your incision in the midline.
And then extend, depending on the pathology you will suspect. Okay, Dr. Das, any other question for the perforation? Then we have a discussion on operative stage for peptic perforation.
We can proceed. One finding: if you suppose after opening the abdomen, if there is acute pancreatitis, what you may get? So to seeing that you may get that it is a case of acute pancreatitis. On opening the abdomen.
On opening abdomen, yes, when you say is pancreatitis.
I'll feel.
Feel the bath don't do right. Feel conductive. Yes. One is it will be hemorrhagic fluid.
Yes, sir.
If it is a pancreatitis, if the fluid may be hemorrhagic, and you can find fat necrosis, saponification, yes, in the omentum, in the peritoneum, and then
yes,
come to the
omentum. Especially if you lift the large gut, transverse colon, in the root of the mesentery near the pancreas, so it will be more in the pancreatic region. So this will indicate that this is a case of acute pancreatitis.
What do you do?
Okay.
You have done a wrong diagnosis. And you open the abdomen. What do you do? You close. Just close. There is a role for putting brain.
Yes, sir.
Okay, because if you have pancreatitis, you don't try to loiter around the pancreas. Okay, in that case, you just put brain in the hepatocyte pouch of Morris and come out. Okay, because there is no role for doing any intervention of the pancreas at this stage when the patient comes to emergency within 2-3 days, and it will mostly be a phlegmonous type of pancreatitis. Okay, there is no role for surgery at this stage of pancreatitis.
Of course, so with the diagnosis of pancreatitis, you close the abdomen, but your diagnosis will be certain. Okay. Then suppose you got you want to see the perforations, the features you can this in the peritoneum.
You find that it's likely to be enteric perforation, and the history is for about 3 days. Patient has got gross fecal peritonitis, and you find the perforation is there in the terminal ileum. What should be the optimal procedure?
Loop ileostome.
Where? You have a perforation in the terminal area, and I said he's got a gross fecal peritonitis, patient is sick. In that case, if you do a primary closure, there is a chance that this might open up. So in that case, option may be number one. You externalize that segment where the perforation is. Okay, and bring out as a ileostomy. Or the option is terminal area. You can close the perforation after fashioning it and do a proximal diversion loop ileostomy. So it is not always required that you always do the primary closure and come out. There is chance of breakdown of that closure. So that is a very serious situation of fecal peritonitis. Okay, that depends on the length.
And in that case, also don't forget to get a small chink of tissue for biopsy from the perforating site.
Yes, sir.
Okay, then we may proceed to the next part.
Yes. So describe the steps of repair of peptic. It's already diagnosed case. You are proceeding for repair of peptic perforation. Start.
Patient, sir, under general anesthesia, patient is in supine position. Sir, I'll take midline incision.
Clean नहीं करता है.
Sir, antiseptic dressing and
So follow. If you are asked operative steps, you should follow the basic steps.
Yes.
First is anesthesia. Next is position of patient. Next is antiseptic cleaning and draping. Okay, cleaning from mid chest to mid thigh, and then drape the patient. So these are the basic things. It's all any part. Some examiner may not like. Chalo, start with the incision. That is different. But your approach should be what is a standard approach for any operative steps. Okay.
Yes.
Yes, of course.
Incision will be midline incision. Sir, skin and subcutaneous tissue will be incised, and the linea alba will be incised along the same line.
How do you identify linea alba while you operate? You cut the skin subcutaneous tissue, and then how do you identify linea alba?
So it is a white fibrous.
The breathing is fibrous, anterior is fibrous. Linea alba is the midline, number one. You find the midline, and you will find there are crisscross fibers. In linea alba, in the midline, you find there are crisscross fibers. Because often you incision, you deviate to the side. So linea alba is identified, this is the midline. And number two, you find there will be crisscross fibers.
From both sides, coming from both the lateral aspect, they are meeting in the midline. Then what approach you may take so that you can stay strictly in the midline?
If you are opening the abdomen, where it is easier to enter into the abdomen, maintaining perfect midline? Yes, near the umbilicus. So if you are taking incision near the umbilicus, you need the umbilicus, here all the layers are totally blended. So near the umbilicus, if you made an incision, you will find that all the layers are blended and you can easily go to the peptic cavity. So once you are there, you remain in that line and go in the midline. Okay. So if you are doing regularly, you can find out midline even from the xiphoid by finding the crisscross fibers. But easier to get the layer in the,
because you can confirm it easily. You can confirm it easily by going through the umbilicus, because there is nothing inside. But in case of GP sternum, unless you are experienced enough, you will get you will get falciforms and thick layers of fat there. So it is easier to start from the umbilicus, and you may stay in the midline following that. Okay.
Then surgical peritoneum hemostatic forceps. Sir, will size in between the two hemostatic and extend.
Usually in the midline, don't separate it. You directly enter the abdomen along with peritoneum. No separate incision for the surgical peritoneum. After skin and subcutaneous tissue go directly into the abdomen through the umbilical region and proceed it, all layers simultaneously. Of course,
So
you may
can go straight with all the layers, or if you're incising near the xiphoid, you can have this linear by getting separated.
Yes.
And it is important to say surgical peritoneum. This is important. I always emphasize that.
Yes.
Do not say peritoneum. Surgical peritoneum comprises what?
So fascia transversalis, pre-peritoneal fat, and parietal peritoneum.
So it's a blended layer. Surgical peritoneum is a blended layer comprising the first transversalis, extraperitoneal fatty tissue, and the parietal peritoneum. So you go through this. Fine.
Yes. So after opening of the peritoneum, there will be gas and bile stained fluid will escape from the peritoneum.
So keep in mind that this gives you a leak. Once you make a nick in the peritoneum, there will be escape of gas. So that indicates that patient has got a perforated peritoneum, that there is free gas in the abdomen.
Yes, then we'll aspirate all the peritoneal fluid out. Then we'll look for the perforation in the stomach and duodenum.
So it's a good practice. Once you open the peritoneum, don't try to go to the site of perforation. Patient is in toxemia. So once you open the abdomen, try to suck out all the collections. So that prevents further absorption. So once you open the abdomen, you suck all the collection in the paracolic gutter, subphrenic space, pelvis. So first you suck that. You can do the lavage afterwards, but initially you just do the good lavage.
Then, sir, we'll look for the perforation, stomach or duodenum. We'll retract the lever upward, downward.
So lever is retracted by? Yes, the assistant will retract the lever by using a lever retractor. And you will pull the stomach
with
down and out
with moist response.
Yes. So now, where is the common site for peptic perforation? Most of the time, how do you find it? In the duodenum.
Duodenum, sir.
Yes. Usually, the first part of the duodenum is the common site for peptic perforation. Yes. So let us repair this duodenal perforation. How do you do that?
Sir, I'll take 3 or 4 interrupted suture with 30 vicryl. The middle knot should be in the center of the perforation. Sir, then I'll take the omental patch and place it over the perforation, and then I'll leave the corners suture knot first, and then center. Last is the center.
Yeah, this is often asked. Which thread you tie first? Because if you tie the center thread first, it may cut through. So it's a common question asked by some examiner that you should close the peripheral suture first, so that it is coming closer, and then tie the central knot.
Yes.
What is this called as?
So it is called Graham's patch repair.
Yes, it's a modified Graham's patch operation for closure of peptic perforation. Yes. So you have closed. What next?
Sir, I'll do peritoneum toileting and with 3 to 5 liter of normal saline, warm normal saline.
Baruna?
Sir, peritoneum.
Lavage, yes. Peritoneal lavage.
Sir, and aspiration. Sir, I'll aspirate contents from subphrenic space and paracolic gutter and pelvis. So drain will be placed over the hepatorenal pouch of Morrison. So then we'll close the peritoneum and linea alba with loop PDS.
Now I find there are some descriptions where people are not putting drain. What is the idea of putting drain here? You have done a good peritoneal lavage. There is no residual peritoneal collection. So why do you put the drain now? You are putting the drain as a prophylactic drain. If the closure leaks, this will drain. But leakage usually occurs in 3, 4, 5 days time. By that time, drain may become blocked. But still you put a drain. But there are some points of not putting a drain. They are the rationalities. Don't put a drain. Follow this patient up. If the patient does not have any features of pain abdomen, localized collection, you do ultrasound. If there is a leak at all and there is a collection, you can do ultrasound guided peak tilt placement. So if you have the facility for this type of monitoring and drainage, you can go without drain.
Yes.
But for your answer, you should say I put a drain.
Yes.
But there are some discussion regarding that. There are options of not putting a drain.
And another important thing, after peritoneal toilet, you always have to mop up. You have to mop up the fluid. You have to clear it by mopping. In one book, I cannot remember, it is written that you have to clear the fluid by mopping because the macrophages cannot swim. So you have to clear all the fluid. Just don't rely on the drain only.
Yes.
Because there may be a collection and then may abscess formation in different pockets.
Yes.
Okay, so it is done. How will you close? Closer?
Sir, I'll close with either loop PDS or number 1 polypropylene.
एक ही बोलो ना, दोनों की बोलते हैं. You close by
number 1 poly loop PDS.
ठीक है. Nowadays you loop PDS as good as a probability which maintains sensor change for about 6 months. So loop PDS. What do you start featuring?
Sir, linea alba and Peritonitis.
Yes. So it's a mass closure. Mass closure taking the linea alba and the surgical peritoneum with a continuous running suture.
Yes, that is.
Once you take the suture, what should be the distance of the suture from the margin and what should be the distance between the consecutive sutures? What is the recommendation now?
And that is for that region, you have to take the sutures in one layer. So for that, initially, you should not separate the peritoneum much, surgical peritoneum. That will be easier.
Yeah.
Initially, as I have mentioned, you should not separate the peritoneum from the surgical peritoneum from the other stuff.
What is the recommendation? Bite from the margin and consecutive bite distance.
From the margin, sir.
Yes. Earlier it was 1 centimeter recommendation. You go 1 centimeter the margin and 1 centimeter consecutive distance. Now people are saying that the optimal bite should be 5 millimeter from the margin and consecutive bite should be at a 5 millimeter distance. So you measure. If you have a 10 centimeter incision, we should do at least 20 bites.
Yes.
And what should be the length of suture you use for the closure of this line?
4 times.
4 times. What is that called as? That is known as? That is Jenkins rule. What if you use less suture? Suppose at the end you have managed to repair with 2 times suture. What does it mean? You mean you have pulled the suture too much. So that causes more tension. So the optimal length of suture would be 4 times the length of the wound. Because if you see, if you go by this margin and consecutive distance, some sutures are used for that looping. So that is how you close and skin by intraoperative sutures. Okay.
Now, you have told that
yeah. Radash, you are muted.
oh,
Yeah, now audible. Yes. Yeah, muted again. Dr. Dash. Yes, Dr. Dash, please.
Now I am audible?
Yes, yes, yes.
Yes. Now, what is what is modified Graham's repair, and what is original and what is modified?
So modified Graham's repair, sir. After sir, first we'll tie the suture, and then we'll place the omentum patch, and then again we'll suture. We'll again take the knot. And sir, in case of Graham's repair, sir, we'll place the omentum and tie the suture.
Yes. Okay. Suppose this perforation is quite large. Then what will you do? Suppose it is more than
Grant ulcer perforation. What is the measure? You cannot bring it closer.
Yes. So then we'll go for it.
What else can be done now? Good enough.
Gastroduodenostomy.
There is another minimal procedure. We should say that. What is Thales patch? What is Thales patch? This serosal patch. So
Yes.
if the perforation is larger, you bring a loop of jejunum.
Yes.
And put seromuscular stitches between the area around the perforation and the jejunal seromuscular. So this is known as a Thales patch or serosal patch.
You
Okay.
may put a larger amount of omentum also, but that may result in obstruction. So you have to do Thales patch, or even you may go for Roux-en-Y patch also.
Yeah.
Roux-en-Y, and if it is a healthy enough, you can go for anastomosis there, or you can just put the patch if it is very difficult to place the loop. Okay.
Suppose perforation in the stomach. You find a perforation in the lesser part of the stomach. Will be anything else to be done?
Yes, sir. I'll take the biopsy.
Why? Why do you take a biopsy?
Sir, because the perforation can be from gastric carcinoma.
Yes. So it can be an underlying malignant gastric ulcer which is perforated. So a duodenal ulcer usually does not turn malignant. So in duodenal ulcer, a biopsy is not required. For a gastric ulcer perforation, you should take a biopsy from the margin and then close. Yes, Dr. Dash, I think we have covered almost.
Is there any role of conservative approach for duodenal perforation?
Yes, sir.
Without
said yes. So you have to now defend that you will be doing conservative treatment.
When? What is the indication? You may go for conservative approach.
Patient, sir, the patient is stable. Patient
Stable. There is no criteria called stable. Criteria is that if there is no generalized peritonitis, number one, and patient is younger age. Yes, and next, you can go for next procedure that is also indicated nowadays. If there is any doubt, you can go for gastrography study.
Because sometimes the perforation gets sealed. Often this perforation is leaking and then it gets sealed off.
Yes.
If it is sealed off perforation, minimal collection.
If it is sealed,
patient may not have that.
For conservative approach. But if there is small leak also and patient is young and there is no generalized perforation below 40 years of age, you can go for a conservative approach also.
Any role
Okay.
for laparoscopic? Any role for laparoscopic in such situation?
Yes, sir.
Yes, there are a lot of experts coming up. Laparoscopic repair of peptic perforation, laparoscopic repair of addressing the acute abdomen. So it is not difficult.
And
You
now
can
it is
put-
well accepted.
So
Yeah,
it
yeah,
is standard course for gastric operations. Do lavage,
Yes.
clean the peritoneal cavity, and you can, if you are skilled at suturing, you can do the same procedure of closure by using uh, intercorporeal suture. Okay. Yes. Laparoscopy.
Have you mentioned the exact, at least know the exact direction of the suturing? You have clear
From
concept?
the line of guts.
Yes. How you pass the needle? Have you seen?
Sir, I'll take first bite
Yes.
around sir 0.5.
First, you have to do it regularly. We have done. So you have to pass the suture first through the tissue to the wall.
Tissue, then we'll bring it from the perforation.
Operation. Then again go for
Then
full
again the
tissue.
other side suture that
Always be very sure, because duodenum is there in more or less upward direction, not horizontal totally. So you have to be careful about that, placing the suture. The suture should be in longitudinal direction so that the closure will be in transverse direction. You have to be very careful. Otherwise, there may be narrowing of the duodenum there. Okay. Is there any role of doing acid reduction surgery along with that?
Patient has got peptic perforation. Is there any role for doing a definitive surgery for peptic ulcer at this stage?
Sir, for definitive management, sir, patient should present early. Sir, there is less contamination.
Good.
And,
Yes.
sir, patient should be general condition should be good.
These are vague terms, general conditions. Usually written in the book, patient should be below 60 or 70 years, not very old. And one important thing that previous history of failure of this conservative treatment of for peptic ulcer disease, and patient is non-compliant to that, you will tell, because you know your job is not finished after doing the operation. You have to give him this H. pylori eradication therapy. Okay. So in that case, see, suppose the patient had got earlier H. eradication therapy, still he got perforation. So there is a role of, if the patient is younger, there is a role of this definitive surgery. As you have mentioned, the patient is fit. Okay.
The point is, this peptic perforation may be NSAID-induced perforation.
Yes.
So if it is a acute ulcer perforating, there is no for the acid reduction surgery.
Yes.
This patient has got a chronic peptic ulcer disease which has perforated, younger patient, hemodynamically stable patient, minimal contamination, and more so an experienced surgeon who can do a vagotomy properly, who can do this surgery in a proper manner, he should do. Otherwise, it's not a job for everyone. Okay.
Yes.
So we have the indication for doing definitive surgery along with the closure of perforation. Okay. There is a question. Somebody say that on laparoscopy we find acute pancreatitis. He said, will the patient survive? You see that what to be done, he said, don't loiter about the pancreas, put a drain and come out. Whether the patient will survive or not will depend on a lot of things. Because now you have the classification of pancreatitis as mild, moderate, severe pancreatitis. Mild pancreatitis, most of the patient recovers.
Yes.
Moderate, guarded prognosis. Some recover, some goes bad. Severe pancreatitis, majority may go bad, but if you give the patient subordinate treatment, this patient may survive. It's not that all severe patient will die.
No. Yes, it is. There is wrong conception. This laparotomy will what's the prognosis? There is several studies that it is not. It is equivalent prognosis. It depends on the severity of the pancreatitis.
Yeah.
Even after operation, patient may be better because you have drained out this high amylase containing fluid and other things, and the diagnosis is short because you should know that what are the indication of surgery in case of acute pancreatitis. One important criteria is where this diagnosis is not confirmed and there is peritonitis. So you have to open it.
So the survival will depend on the severity of pancreatitis
Right.
and the progress.
Prognosis will depend on the severity of the pancreatitis, not for the operation.
You see, there is another question. Somebody says that there is perforation of proximal jejunum and patient not suitable for primary repair. There is a very important scenario. What we started discussing is if the patient is having a poor general condition with a low protein, reduced hemoglobin, and then gross peritonitis, even this area where is a proximal jejunum, if you close and put it in, if it opens up, patient has a very hectic course. So situation in like this, what you should do is you can do a extravasation of this gut and put a tube, put a feeding tube distally, so that whatever is draining, some amount will be returned. Because all depends. If just because of what you are scared of is if you do a diversion in this area, there will be huge output to the tune of 4-5 liters. So you have to manage this patient with IV fluid, parenteral nutrition, and some of this fluid will be returned back to the distal tube put in the jejunum. But all depends. That just because it will put more output, you close and come out, and if this leaks, you have horrible time. The extraction can be done even in this situation. Okay, Dr. Dash, thank you so much. Any questions from anybody? No.
Yes. Okay. Thank you for the presentation. Okay.
Thank you.
Okay. Thank you.